So this is sort of a longer journal article. I'll try and keep it pretty brief, but this is out of the Annals of Internal Medicine. First, I'm just going to address my research question, and then we'll see how this article can relate. So, can concierge medicine serve as a viable solution to address provider shortages and reduce wait times? And what are the implications for accessibility and equity? And I think this article does a pretty good job of addressing both parts of that question. So right away in the abstract, it actually says just that. It kind of states the question posed in my research question. So they call them direct in this article. It's going to call it a direct patient contact contracting practice. So the move to direct patient contracting practices is based on the premise that access and quality of care will be improved without third-party payers imposing themselves between the patient and the physician. So yet, and this is going to be a common critique of this model of healthcare, concerns. Oh shit. Well, okay. Concerns have been raised that direct patient contact practices may cause access issues for patients who cannot afford to pay directly for care. So that's one of the concerns that I'm going to be trying to research throughout this project. Because that kind of directly correlates with my research question. So let's look at the effects on access. Because, let me just highlight that, because direct patient care practices or direct patient contract practices often limit their patient panel size to several hundred compared to 2,500 plus, so drastically reduced panel sizes. There's a concern that downsizing, especially when associated with retainer fees, whether they're monthly or annually, would create a barrier to lower income patients, patients with chronic disease, and other underserved populations. So we'll just be aware that that's going to be one of the larger critiques of this model, and we'll keep that in mind going forward. But one of the things to note about these direct patient contract practices is that because of these retainer fees, there's availability in these models to either accept healthcare insurance or out-of-pocket fees. So that's, in my eyes so far, the potential to actually increase availability or accessibility and give people the option to either, if they have insurance, they can rely on that. If they don't have insurance, the retainer fees would cut down potentially on different medical costs, whether it's exams, tests, things of that nature. So effect on cost, let's see what this has to say about that. So this is really just going to say what I just said. The direct patient contract practices, advocates assert that price transparency, competition, lower administrative costs, and patients accepting more personal responsibility for their costs will keep out-of-pocket costs and overall spending down. So basically, these practices may be generating their revenue from other sources rather than like patient medical care fees. So by paying that retainer fee or like that premium for the membership or whatever you want to call it, it would allow for lower costs for medical care, the actual medical care. However, critics observe that these practices can leave the patient at higher risk of out-of-pocket costs for healthcare. So, let's see, effects on the workforce. That's going to be the other part of my question. So, practices that downsize patient panels could potentially place an even greater strain on physicians that remain in the larger system. So, there's kind of two sides to this, right? So, if physicians are leaving our current like mixed healthcare system to go to a concierge or direct practice system, it's gonna create a larger strain on the physicians who stay or who remain in our current healthcare system. However, because of the shortages and because of the kind of excessive workload for a lot of these providers, that transition to these direct patient contract practices may reduce burnout and may keep a lot of these physicians in practice rather than closing their practices altogether, due to an unmanageable workload. And unfortunately, it's saying that the effect of these practices on the workforce shortages requires more study. So we'll see if we can find that somewhere else. So basically, what this article is saying is in support of physician and patient choice. So there should be the freedom to choose on both sides, both the physician and the patient, to choose what practice suits them best, based on all of these factors that we've talked about, whether it's cost, accessibility, or for the physicians being overworked. But it's saying that the physicians need to take into consideration the ethical and moral considerations in doing so, and what effects that may have on certain populations, especially underserved populations.